Hello, everyone. Thank you for being with us today. My name is Rose Gerber. I'm the Director of Patient Advocacy and Education for the Community Oncology Alliance. I'm excited that you're here with us today. As I just said, I want to wish you a happy new year. I hope you all had a wonderful holiday season. And I'm excited this year for another series of great advocacy chats. And the purpose of these chats, they're only 30 minutes and we pack in a lot of information, is really to keep you updated on any national healthcare policy issues that are impacting patients or anyone in the cancer care community. And to kick off our season, I'll say season because I know there's a lot of sports fans out there, is our very own Ted Okon. And he's a healthcare policy expert. He spends a lot of time on Capitol Hill. And we're very lucky to have him with us today. He's going to give us a broad overview and dig in deep on a couple of topics that are of interest to all of us, particularly drug pricing, because there are some concerns that we're all very interested in. The cost of cancer care is one of them. So Ted, thank you so much for being with us today. Can you go ahead and advance the slide, please? I want to take a quick little look at bullet point number 2, and I like the fact that the word cancer care or care is underlined, because when we think about cancer, there's so many segments and so many important pieces to the cancer care experience or to the cancer experience, whether it's research, funding, but what we really focus on at COA is the care component. So Ted is going to give us a lot of insight into that particular topic. And he's going to also tell us what to expect at the federal and state level and give an overview of COA's priorities for 2022. So welcome, Ted, and thank you again to our audience for being with us today.
Great, thanks, Rose. So you talked about jam-packed. I'm going to jam-pack everything in here. And if you'd switch to the next slide, please. So, you know, if you ask the question, what are the biggest issues related to cancer care policy? And again, Rose underscored the idea of care. It really comes down to drug pricing, drug pricing, drug pricing. So I'm really going to devote this 30 minutes for the most part to looking at some of the aspects of drug pricing, because why? Cancer drugs are expensive. Many politicians love to bash pharma. You know, and that's kind of, and I have to say, and I'm not going to make any apologies or excuses for some of the things that pharma does on drug pricing, but, you know, I have to say that's regardless of the fact that pharma is what pharma is doing to deliver some of the most incredible in light speed vaccines and antivirals out there. And so it's kind of interesting because, you know, it's really easy to point fingers at pharma, but the actual problem is a lot more complicated. Now, I'm not going to try to get too much in the weeds and get too, as our head of communications, Nick Ferreros, would say, wonky about this, but it is a little bit wonky because it's really easy to say, oh, the problem with drug prices, the problem that I pay on drugs is literally in a pharma problem, and it's not. Pharma's certainly on the hook for basically the underlying drug price, but the thing that I want to underscore here is the fact that when an American, basically, when somebody from this country talks about drug pricing, for the most part, I'm talking about a patient or someone who's buying drugs, it's about the cost to them. It's not about the underlying price. And that is so important because if you look at the drug cost, it's a function of several factors. It's a function, obviously, of the drug list price. The higher the list price, you would think the higher the cost is, but that's not always the case. It's a fact of benefit design, meaning your insurer, what's your copay, what's your coinsurance, what's your deductible, all have to deal with that as well too. It's gonna, as I'm gonna show you, it's about what your provider does in terms of marking up drugs, in terms of what the cost is to you. And then it's also a function of insurer formularies. That's not only the idea that you may or may not be able to get the drug because it's on a formulary, which is sort of a restricted list of drugs, but it's because of what the insurer, or we're going to talk a lot about pharmacy benefit managers, does in terms of the formulary and the kind of the rebates they get, therefore the way they set the price of the drug. So this is a very complicated issue. And when anybody asks me what are the biggest topics in cancer care policy right now, and not only in Washington, D.C., but across the country, it's drug pricing. So next slide, please.
Ted, can we just, before we jump to the next slide, can you also just give a highlight of what you mean when you say provider and what a formulary is?
Yeah,
because we
yeah.
have an experience.
Yeah, so let me go backwards and say that a formulary is literally a restricted list of what drugs you can have. It is literally saying that the drugs on formulary or the drugs on this list are the drugs that you have available to you. And if it's off formulary, even though your physician may say, this is the best drug for you and it's off formulary, the only way you're going to get access to that drug if there's a special exception that your insurer makes. And a provider, I use the term loosely, but generally providers are medical providers, they're physicians, they're hospitals, entities like that. So, okay. So the reality of drug price dynamics is a list versus a net dynamics. What does that mean? Think about you go into the car showroom. Now, this is a bad time to talk about this because generally you go into a car showroom and you look at the sticker price or the list price on the side of the car in the window. And then the way the market is now, as crazy as it with COVID, you may be paying above that. But think sticker price as list price. The same thing with a house. The net price is literally the net price after rebates and other mechanisms that brings down the list price. So this is very interesting. And again, I'm not taking and defending pharma. I'm not taking literally the pharma position and being apologetic, but because I look at what Biogen has done with his Alzheimer's drug and drug pricing, and it's inexcusable. So pharma definitely has a role here. Pharmaceutical companies have a role here in setting list prices, but it's a very interesting dynamic. So what do I mean? Well, if you look at the 6 companies on this list, Lilly, Janssen, which is a part of J&J, Glaxo, Merck, Novartis, and Sanofi, this was actually published in terms of out of drug channels published this, that this was literally the average list price change. So if you look at the list prices of all these companies, they went up. But if you look at the net price, which is the B column, they went down. So the difference was a 6% difference between literally a list price up versus a net price down. Now you're going to say, well, why is there a difference between a list price and a net price? And I'm going to show you something this in a minute. But it's very important to understand there is a fundamental difference here between what is the list price. And that's what, when everybody says, oh, drug prices are too high, and, you know, the politicians or somebody quotes or the academics, they're talking about that. Next slide, please. So this is literally some more reality on drug prices, okay? And this is going to tell you part of the tale of list and net prices. This literally, and I'm sorry, this from BRG, I forgot the source on this, Berkeley Research Group, just put out a paper on this. And what the left pie chart shows, this is amazing, that the middlemen in what we call the supply chain, so pharmacy benefit managers, hospitals, I'm going to touch upon both of those, literally get the majority, 51% of the, basically the share of gross drug expenditures go to them. Only 37% go to brand manufacturers and the 11 or 12% to generic manufacturers. What does this mean? This means exactly what I told you, that pharmaceutical companies also have to set their list prices higher because they're going to get hit by rebates and discounts and all of these things that bring the net price or what they get from this down. And if you look at the graph on the right, the timeline graph on the right, it shows you from 2013 to 2020, the manufacturer, the part of the revenue that they retain from the drug sale has gone down and the part has gone up. And for the first time, the entities in the supply chain, and I'll explain that, it gets a little wonky, but literally make more money off of drugs than the drug manufacturer does. So next slide, please. And this will become clear in a minute. So hospitals profit from drug prices. In fact, we did a study, and I don't have time to go into it. It's up on the COA website. You can access it. But we looked at literally in the study, the median hospital markup, and these are at 340B hospitals. These are hospitals, over half of the hospitals in this country, that get special discounts on drugs. And literally, when you look at their median markup, they are charging 3.8 times more than the cost of the drug for them. In fact, in a drug like Epogen, which is a drug used in cancer supportive care, it's 11 times. So hospitals have a tremendous markup. And please click on this slide one more time, please. And the interesting thing is these 340B hospitals that are supposed to basically use these drug discounts for the community and basically to take care of patients in need, they charge virtually the same median price for cash paying or uninsured patients, because anybody paying cash for the most part doesn't have insurance, as they do for insurers. So think about that for a minute. These are entities and hospital entities that are literally supposed to help those in need. And anybody who's in need because they're uninsured is getting charged the same price as an insurer, and a huge markup. So what does that mean? Go back to what I said about list and net. Is when you walk in and you're getting the bill from the hospital, it typically will have a huge markup. So your cost, whatever your portion of the cost is, it's artificially marked up. And that's part of the problem here, because this has no relation to the drug price. Yes, there's an underlying drug price. Yes, it's marked up from there, but your cost is out of bounds. So next slide, please.
Ted, can you also, since you're on 340B, can you also talk about how this impacts like incentivizing the purchasing of community oncology practices?
Well, yeah, I mean, and that's a whole nother story, Rose, but very simply is the fact that because hospitals make so much money on drugs, especially cancer drugs, they have a huge incentive to pressure community oncology practices, independent practices that are not part of the hospital system, to sell to them. Because, and when you go in, I mean, we have story after story of where a hospital buys a practice, a patient is in, let's say it's after their third cycle of chemo, and they're going in for their fourth, and it's the same building, the same nurse, the same doctor administering everything, but they get their bill, and their bill is out of control. Why? Because here's the markup. So let's take an example. This is a drug used for multiple myeloma, Darzalex. And literally when you walk into the left side of this slide, when you look at it, you walk in a community practice, and if this is a Medicare patient, and the way Medicare reimburses, in essence, the gain that the practice makes. And remember, this isn't like some profit of $7,000. This goes to pay for literally the procurement of the drug, the storage of the drug, the preparation of the drug, and all of that. But literally on that Medicaid patient, for a year's worth of Darzalex, so a patient on Medicare taking Darzalex for a year, literally the community oncology practice has purchased a drug for roughly $117,000, and they're reimbursed roughly $124,000. Now, go to 340B hospital and look at that Medicare patient. And it's a Medicare patient now. And because Medicare sets what the reimbursement rate is, the hospital is actually making double. They're making $14,000 on this. But look at what happens when it's a commercial patient, a patient who either actually could be an uninsured patient, because I just showed you how it's the same, the uninsured patient gets the same as the charges as the insured patient, but it is literally a commercial patient. So you have insurance. The drug was purchased for $76,000. Why? Because just like in the example with the other hospital, that's what their purchase price is because of the discounts at 340B. They are pricing it to the insurer for $290,000. Their profit is almost $214,000 on a course of a year's worth of Darzalex to that patient. So this shows you, again, in this case, there's no correlation between that drug price literally and what it's charged. So it's pretty crazy. Next slide, please. I want to make sure I get through all these. So PBMs, they're pharmacy benefit managers. These are some of the top Fortune 100 corporations that control virtually all of the prescription drugs in this country. And think of them as sort of a water meter, basically. They don't own the water, they don't supply the water. Basically, they have a meter on the water. And what they do is they are involved in literally controlling prescription drugs. And the top 3 of these are also tied to the top largest health insurers. And the top 3 alone control upwards of 80% of all prescription drugs. So that's CVS. CVS is a pharmacy benefit manager. They own Aetna. Express Scripts is a pharmacy benefit manager. They're owned by Cigna. OptumRx is a pharmacy benefit manager. You're owned by United Healthcare. And these pharmacy benefit managers basically started out by helping sort of adjudicate or process claims at the pharmacy level. What they do now is they go to a pharmaceutical manufacturer and they basically, they're the intermediary between a pharmaceutical manufacturer and an insurer or an employer. And in many cases, insurers, the PBMs are the same, but more employers are self-insured, and basically says, we'll negotiate these drugs. But the problem is they profit from higher drug list prices. So they have a vested interest in that higher list price, because the higher the list price, literally the more they profit. So what do? They go to a pharmaceutical manufacturer and they say, you won't appear on our formulary, meaning you won't appear on this approved list unless you give me this 50% rebate that gets pocketed by the PBM. That literally is off of the list price. So they want the list price to be as high as possible. They also basically extract, and some would say extort in both of these situations in the true sense of the word, these after sale fees from pharmacists. And literally they are fees that are, when I say after sale, after you've gone in to the pharmacy or you've gone into your oncology practice, got your drug in the case of an oral drug, and basically 3 to 6 months later, the pharmacy, whether it's attached to an oncology practice or not, gets hit with this bill for these fees. Well, what are these fees? You can't really figure out. We call them DIR, stands for direct indirect remuneration fees, but they're literally almost play to pay fees, or they're sort of pseudo quality fees. But the bottom line is, if the pharmacy provider says, I'm not going to pay those fees, then the bottom line is they're out of that network. Well, go back to the first bullet, where where literally the 3 top PBMs control 80% of the prescription drug market. So then you can't process any drugs, provide any drugs to literally somebody who's part of CVS or Aetna, Express Scripts or Cigna, OptumRx, United Healthcare. So again, the message here is that's what happens, is that this list price, they profit, whether it's basically extorting these rebates from drug manufacturers or downstream, as I call it, with pharmacists getting these fees. And in fact, it's no different than, the mob guy who walks into a deli, I hate to say this, and says, do you have fire insurance? And the deli owner said, I have not had a fire in 25 years. Well, you may have a fire and pay up. I mean, it is literally in a true sense of a form extortion. Now, and I'll come back to what's happening in this in a minute. But you have to also understand, that drives me crazy, that the PBMs and the associated insurers adversely impact cancer care. They not only sort of fuel drug prices bigger, and I told you I was going to focus on drug prices here, and I'm not going to go into this a lot, but they restrict and in some cases delay, in some cases even deny treatment, because they not only control these formularies, but they control things like what are called step therapy, where you have to get an inferior drug before you're going to get a superior drug. So this is a real big problem. Next slide, please. So, you look at what I called formulary. Again, this is from Drug Channels. It does a great job of looking at this. These are pharmacy formulary exclusions. What this shows you is for those top 3 PBMs that I just told you about control 80% of the prescription drug market. If you go back to 2012, really Caremark, which is CVS, literally was the only one having some of these formularies. You go to basically now 2021, and you see how many number of drug products are excluded by Caremark, Express Scripts, and Optum Rx. So it is a real problem in that more and more, literally patients, regardless of what they have, regardless of what's wrong with them, regardless of what specialists, but especially in oncology, more and more literally don't have access to certain drugs or are required to have an inferior drug before a superior drug. Next slide, please. So my crystal ball on DC drug pricing initiatives. What do I think is happening? Well, I think everybody knows we've been saturated with the Build Back Better Act, that in that Build Back Better Act, this was a Democratic initiative, as you well know. This is very, 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 very partisan issue. They tried to advance the Build Back Better and to allow Congress to negotiate prescription drug prices in the Medicare program. And a lot of people say, yeah, I want Medicare. They're the biggest purchaser of drugs and services. I want them to use their weight to negotiate prices down. The problem with that is that the approach in this Build Back Better Act, which basically is now pretty much dead in the water, is it deals with prices of drugs with no competition after they're on the market. So it could even fuel list prices, because you could have pharmacists say, well, wait a minute, down the road, if I don't have any competition, they're going to knock this down because there's no negotiation. It's not when you have the only product that works in the market, there's not a negotiation. It's going to be the government saying you're going to take it or leave it. And by the way, if you leave it, you're going to have to pay a 95% excise tax on all your sales. So the bottom line is not a negotiation. So it could even fuel manufacturers in setting their list prices higher. But what I just showed you, this doesn't stop PBMs and hospitals from marking up and fueling drug prices. In fact, to the contrary, what we call the unintended consequences of legislation, that means what we don't see happening about a certain bill, it could even literally cause greater markups by hospitals and PBMs in terms of fueling drug prices. Again, I'm not letting pharma off the hook. But the worst thing about this is, and people said, Ted, why is COA so against this provision in the Build Back Better Act? We actually said, fine, you want to go through this negotiation, you want to see what happens. It may hurt innovation, but I'll tell you what, take providers out of the middle, because what this bill did and the way they went about this negotiation, it put providers, and specifically oncologists, in our case, in the middle of literally having a artificially lower reimbursement due to the negotiation. Again, I'm not going to go into it because this is a very wonky topic, but we offered language, legislative bill language, to say, look, all you need to take providers out of the middle, have manufacturers rebate the government directly. Don't put oncology practices, they're oncologists, in a position where they're not financially viable. Because what does that mean? That means that, as Rose talked about before, they end up in the hospital and patients end up paying more, or basically they close their doors. And we know that's all happened in the last 10 to 12 years. So the Build Back Better Act is now dead in the water. The Democrats may try later to advance drug pricing initiative. This is a big thing on the president's desk, especially on the Democratic side of the aisle. I just don't know how they're going to do it. And until we see the dust settle with this Build Back Better Act, and as you know, the holdout on the Democratic side with Senator Manchin, I just do not see right now how this comes back, because they need every Democratic vote. And then the tiebreaker is the president and the Senate, which is Vice President Kamala Harris. Because not Republicans are going to not work on this. But again, my message is, even with this Build Back Better Act, the way they were doing it was really destructive. Very interesting that the House Oversight and Reform Committee held a forum. I said a forum/hearing. Why? It wasn't technically a hearing. Why? And again, this isn't a political message, but the Democrats on the committee wouldn't basically go along with the Republicans. So you can't have a mail order. You can't, excuse me, mail order. You can't have you can't have a hearing unless you have it's bipartisan. So basically it was a forum, but the highest Republican held a forum. I testified at it, and it was all about PBMs and literally how they fuel drug prices. And, afterwards we looked at, and I met with the Democratic side and said, you guys got to get on board here. Very important. So, what's going to happen more while the BBB is dead on this PBM issue? I think you're going to see more of this effort, especially by the Republicans on the House side. Next slide, please.
Excuse me, and I'm pretty sure that we have a clip of your the
forum, the hearing, right.
The brain got frozen for a minute there. So if anyone wants to view it, it's online.
Well, I will say, and I am hoping, and I will say this, I don't have this on the slide, but Senator Wyden, who is a Democrat, who is the chair of the Senate Finance Committee, has been very, very vocal about PBMs and especially these after sale fees, as said, DIR. And what's nice about this is last Friday, the Biden administration moved to force PBMs to disclose all of these fees and do it up front. So when someone under Medicare goes into a pharmacy, they will pay the lower net price, and it will include any of those after sale, rebates, DIR, these fees that go to pharmacies. So this is really the first meaningful step to acknowledging that drug pricing is not all about the pharma problem. In fact, it's amazing because, again, this is the Biden administration. It's a Democratic administration. The president has been very fierce about pharma and all that. But this is the first time there's been acknowledgement that you can decrease costs for patients, drug costs, literally, and it's not just a pharma problem. And PBMs are the real problem. So this is really, this is actually really exciting. Next slide, please. So let me give you some crystal ball on state drug pricing initiatives. It's wow. I mean, you can see here, these are some headlines. It shows you that state after state after state. Just recently, this is the governor of New York that signed landmark legislation bringing transparency and comprehensive regulatory structure to otherwise unregulated pharmacy benefit managers. We've had state after state literally come forward. Even the Supreme Court literally upheld what was a controversial Arkansas law that regulates pharmacy benefit managers. Wow. The states are actually far ahead of the literally of the federal government. And it's because so many people have been active, including a lot of oncologists that I know in a lot of different states that have gotten great legislation passed. So, and COA, we're going to do a lot more on the state level. So next slide, please. So what are some of our priorities? Bring down treatment costs for cancer patients, specifically drug prices. We want to advance legislation that all of these 340B discounts wouldn't go to hospitals, wouldn't go to funding, CEO bonuses, but would go directly to patients in need. That's what it is. So we want to advance legislation on that. We want to advance legislation that would stop PBMs from denying and delaying cancer treatment, which happens now, especially when they restrict where patients get their drugs. You can't get your oral drug from your oncology practice. You have to get it from the PBM's mail order pharmacy. We want to basically stop this denying and delaying when a cancer patient can't get their drugs within, literally, 72 hours. The support legislation and the Biden administration in stopping PBM rebates. There are a number of bills in the Congress, and these after sale pharmacy fees that artificially fuel drug prices. We want to stop restrictive PBM and insurer tactics that limit cancer treatment options. The idea that cancer patients shouldn't get the drug and be able to get the drug that his or her oncologist wants is just mind-boggling to me. We want to stop misguided public policy that puts community oncology practices in undue financial harm, because that leads to clinic closings and mergers into the more expensive hospital systems. Next slide, please.
Ken, I got to jump in on that one. When clinics close, and this is where the patients really have to picture this in their mind, you no longer have access to that community oncology clinic that you've formed such a bond with. And that's really what this is all about, is that's going to be gone. So it's such an important issue.
Especially in rural areas. So next slide, please. And, you know, we have a lot of priorities, but two of our biggest priorities are helping practices continue to navigate COVID-19. I mean, this has just been a disaster. We've heightened the awareness of the impact of COVID on cancer screenings and treatment. In fact, we've launched a major public service announcement campaign, Time to Screen. You see the write-up in the Washington Post. This is actually Dr. Patel, our president's office, and it talks about one of his patients, Dr. Deborah Pat, one of our board of directors and an officer, her patients, because unfortunately, COVID has delayed screenings. Delayed screenings would mean that people come in with more advanced cancers. This is really a tragedy. So I could go on for 5 hours about this, but just to say this is a priority. And I think that's tied into that is work with especially employers to understand how they can provide their employees with the highest quality, most affordable cancer care close to home. And that is also all of their employees. So one of the biggest things that we have on our plate is this idea of health disparities. Everybody's talking about health disparities. Everybody talks about let's do something. We're actually doing some things, and topic for another conversation. Rose can have some people on who can tell you more about that. So next slide, please. So my crystal ball in the midterm elections, you know, right now, look, it's a long time before November, but even you talk to most ardent Democrats behind the scene, and they will tell you that the Republicans take the House and probably the Senate. The reason why the Democrats wanted to go so big on the Build Back Better Act was because, because they're afraid that they're going to lose the House, and they got one shot at this. And that's a big deal. In fact, I was listening to CNBC this morning, and the head of the Progressive Caucus was on, and she said, "Look, it's a bipartisan issue, that childcare and all this healthcare and these issues." And Becky Quick this morning said to her, "Then why haven't you started out working on bipartisan stuff and doing that? Why did it have to be one big?" And Becky Quick is, probably well left of center. So a very interesting question. But the $60,000 question, I think, is, will a divided government bring policy together, that they have to work together, or force them more apart? Because I've never seen Congress as divided as the 20 years that I've been up there. Republicans will likely put less emphasis on pharma and drug pricing investigations, and more in the middleman like PBMs. You saw that already with the House hearing and all that. So next slide, please. I will certainly, Rose, answer any questions. I decided to put this shot up in thinking about the Olympics, because this is a couple of years ago. Scott Hamilton spoke at our conference. I had the opportunity to go down at House and do some video filming with him. Obviously, Olympic gold medal in skating, and so I thought that was a very timely picture. But Rose, certainly, I know there's some Q&A stuff, and there's some chats. Somebody asked, just real fast, if I can, when will the public health emergency be extended? Right now, the public health emergency is in place. So I don't think it's as much as extension as literally it needs to be, they need to pull it down. I think right now, the public health emergency, it's tough to pull it down when you've got all the Omicron statistics, but we don't have any indication about that. That's the HHS secretary, and we'll actually try to find out. Someone said, I went to United Healthcare when I was put in the Medicare disabled in 2020. I'm a Walgreens preferred provider for best price. Then I was contracted by OptumRx to receive my meds through the mail. And then at an even lower cost to me, how is this affecting drug prices, Medicare, and consumers? That's called trolling. Literally, companies should not do that. And there's a problem here is when they troll, because in many cases, patients find out that their costs are not less, and the prices they're not paying are less. And Walgreens really doesn't have a big active PBM as the other ones do. So literally, the control of the prescription drug market in terms of the PBM side is really starts with CVS and as I said, CVS and Aetna, Express Scripts and Cigna, and then United Healthcare, and also their Optum Rx, which is their PBM. So Rose, I think that was some of the questions and stuff. I don't know if you have any. I know
Yeah, no, that was
terrific.
terrific. Thank you, Ted. That was really great information. And we know there was a lot of content. And I want to remind everyone that this will be on YouTube in a couple of days. So thank you for participating. And also, I encourage you to follow Ted. He has a lot of great information to share on Twitter, and also follow COA on Twitter. And Ted, this picture of Scott Hamilton, I'm remembering what an incredible keynote speaker he was. So he reminded me about everything that's so important about getting involved with advocacy. He was inspiring. He was willing to learn more. He was humble. He was just a really great person. And I've heard a lot of keynote speakers, and he was definitely.
Yeah, well, I'll tell you, Rose, a little funny story is as they were setting up the video cameras and everything to do that and stuff like that, here's Scott Hamilton making a PB&J for one of his kids. I mean, you can't get more normal. Yes. And American. I mean, it was just a great conversation. He's a great guy.
Very memorable. Thank you, Ted, for your time today. Yeah. And we have one last slide before we say goodbye to everyone. So join us again next month, February 2nd. We're going to talk about the financial crisis of cancer and have some solutions. We have a terrific speaker, Carla Tardif. She's been in the advocacy space for a long time as well. She heads Family Reach. It's a great organization. And thank you all for kicking off the new year with us. And keep on learning with us as we go forward this year. Thank you, and enjoy the rest of your day.